Joining us now, Trina mentioned many times Medicaid 1115 waivers, and we heard the word Massachusetts. I'm really delighted that we have Kim Pendergast from Massachusetts Community Care Cooperative, which is an accountable care organization, joining us virtually today. Massachusetts, we all know that in California is kind of one of the leading states in food as medicine, and we hear about them getting waivers, and we're like, oh, they figured it all out. They're the holy grail. It's one of those blue states. Kim is going to tell you a little bit about how that's unrolling out, and she'll probably share the good, the bad, and the ugly about it. So this is a great opportunity to listen to Kim, Vice President of Policy at Community Care Cooperative, and at one point we'll see her on the screen and not Amy. There we go. Sorry. All right. Good morning, Kim.
Good morning. Thank you so much for having me. It's great to be here, and I am fired up after Trina's talk there. So I'm excited to share a little bit about what we're up to in Massachusetts. A little bit about me. I spent about 20 years working at Feeding America, so I think I know some of the folks in the room doing a variety of work around nutrition and healthcare partnerships and our work around research on food security and diabetes, really thinking about how the social service sector and the healthcare sector are, oh, sorry, can you hear me okay?
We think it's on our end, Kim. We're trying to adjust the mic a little bit.
How's that?
We can hear you faintly, but again, Ronaldo, is it on our end? Do we think we have it? Save me, Kim.
All right, can you hear me?
Yes, we
Good.
can hear you.
All right, wonderful. Thank you. Sorry about that. So just wanted to level set a bit. I spent about 20 years working with Feeding America, so hello to my food bank friends, and really brought that perspective on the work that we had done around food banks and healthcare partnerships and understanding food security and diabetes and other chronic diseases to this role that I'm in at Community Care Cooperative. Let me just share my slides. Are you able to see my slides? The chat is longer. So, Elizabeth, can you give me a thumbs up if you can, or let me know? Yes. Okay.
Yep,
perfect.
we can hear you and see you.
Good. So what I wanted to talk about today was just a bit about what Community Care Cooperative is, the organization that I work with. And then I think a lot of folks probably know about Section 1115 Medicaid waivers, but wanted to share a bit about that process so that we level set and understand what's possible in states where they don't exist today. And then I'll tell you about the program that we are running for food as medicine in Massachusetts. And then we'll take the slides down and hopefully have some conversation. So, about my organization, Community Care Cooperative, we go by the acronym of C3. And we are a federally qualified health center, or FQHC, also health center. I may use that term through this discussion today. So we're a federally qualified health center-led accountable care organization, ACO. And an ACO is a group of healthcare providers that come together to manage the quality and the costs of a population. And so as an accountable care organization, we brought together health centers in Massachusetts for the Medicaid contract, and then we've expanded from there. And our mission is really to leverage the strengths of health centers to improve the health and wellness of the people we serve. And so just a little bit more about what an ACO is. Really the goal is to bring providers together to think about the workflows to ensure that patients get the right care at the right time without providing unnecessary services and procedures. So providing high quality care and a great member experience, and then pooling the shared savings from those programs by spending our healthcare dollars more wisely. And for us, that means that when we're saving money because we're providing good care and it's costing less, we're able to reinvest those dollars in our health centers, in their workforce, and in programs that address social needs and improve health equity. So that's a little bit about the lens that I bring in this role at C3. And our story, we started in 2016 When the Massachusetts Medicaid program changed to create the accountable care organization structure for Medicaid or Mass Health. So we launched that contract in 2018 with 15 health centers, and we've grown over the last 6 years. So we have about half of the health centers in Massachusetts in our Medicaid contract. We launched our flexible services program. Now we have a technology subsidiary and a pharmacy subsidiary. And we're also working in Medicare and in commercial contracts and in 7 other states. So today I'm going to mostly talk about our Medicaid work, but just to put that perspective there is that we're working with health centers across the country today, really trying to share the work that we've done in Massachusetts. So we talk a lot about social health as our overarching umbrella for this work because we believe firmly that to provide good patient care, it's understanding the physical health, the behavioral health, and the social health needs of our patients. And so that involves really 4 pillars. One is identifying health-related social needs, or HRSNs is the term that's being used. And so that looks like screening our members directly. We're asking questions in person when they come for a visit, when they're having a telehealth visit, when they're on the portal for their health center. And we use the Accountable Health Community Screening Tool. So really trying to understand what those needs are and documenting those needs in the electronic health records with Z codes. And that's really where the world seems to be going, that it has to be documented and coded for this work to move forward. But that is really just the first step. And so our next step is thinking about how it is that we can support all of our health center staff to effectively connect patients to community resources. So we're doing lots of trainings and webinars and on food insecurity and other needs. We have a Find Help resource and referral platform. It is just our basic work to make sure that our health center staff can address the needs of their members. And then importantly, in the conversation that we'll have here today is thinking about the ways in which we as an ACO can invest in programs and partnerships to expand the capacity. We know that healthcare organizations can't just screen members and refer to food banks, refer to grant-funded programs, charitable-funded programs in the community. We need to invest and expand that capacity to make sure that we're able to build up what's available to our members and our patients to assure that they have access to healthy food, the right kinds of nutrition, the right kinds of meals to support their cardiometabolic needs, all of the diet-sensitive diseases that they have. So we're investing dollars through flexible services. We're finding other kinds of funding sources to support those needs for other members who don't qualify for flexible services, and also creating partnerships to really expand SNAP and WIC application support, again, making sure that the capacity exists. And then we spent a lot of time thinking, and which is why my role has expanded to also be Vice President of Policy. I'm thinking about the policy and advocacy work that really falls into this. And we feel a lot of responsibility as one of the first in the nation states doing this work and accountable care organizations doing this work, making sure that we're sharing some of those learnings. So that's a little bit about the organization where I work. So just wanted to talk a bit about 1115 waivers in general. You hear a lot about 1115s, there's a variety of waivers in lieu of services. And the Section 1115 waiver is probably the most common that you see to support food as medicine work. But just to give a little bit of background, that it's called Section 1115 because Section 1115 of the Social Security Act gives the Department of Health and Human Services, and therefore the Center for Medicare and Medicaid Services, or CMS, the authority to approve demonstration or pilot projects for state Medicaid agencies. So the state would apply for a waiver under this Section 1115 option, and they can approve projects that promote the objectives of Medicaid and demonstrate and evaluate state-specific policy approaches. And so that's kind of the overview. Waivers are generally approved for 5 years, and they can be used in a variety of ways. So we're talking about them for food as medicine programs, but important to recognize that states are also thinking about how to use an 1115 waiver to expand eligibility, maybe to assure continuous enrollment. So in Massachusetts, we've also been thinking about how to keep pregnant women on Medicaid for longer to assure that they have access to the care that they need. expanding benefits. There's a lot of work thinking about how an 1115 waiver can be used for behavioral health supports. So when we talk about Section 1115 waivers, especially with our Medicaid counterparts at the state Medicaid agency, important to think about, they're not just for health-related social needs, though that's such a great use of an 1115 waiver. So many 1115 waivers allow for nutrition and food as medicine programs, as well as other health-related social needs. We're seeing lots around housing. We're starting to see more around supports for individuals who are justice involved as well. And there are currently Section 1115 waivers for nutrition supports that look a little bit different in different places, but Arkansas and Delaware have them. They were a little bit earlier and a little bit more narrow. Massachusetts, North Carolina have pretty robust programs. North Carolina is a little bit different, but similar to what I'll talk about today. New Jersey, New York, they just had theirs approved a couple of weeks ago. So congratulations to New York, as well as Oregon and Washington. So other states starting to get started with this. And as Trina mentioned, in November of 2023, CMS actually issued some guidance on allowable health-related social needs services. So this is a link to that table that was actually in Trina's slide that really spells out what's allowable. So when Massachusetts was doing this and North Carolina was doing this, we had kind of a blank page that they had to start with and request some things, and CMS said yes or they said no. And now they've really codified, these are the things that are allowable. You may wonder where California is in this list. California's supports are all under in lieu of services, as opposed to 1115 waivers. So they have some similar kinds of programs, but it's just funded through a different, or allowable through a different kind of waiver. So our program in Massachusetts, as an overview for, we call it flexible services. And this was the program that started, it was allowed through the 1115 waiver that kicked off in 2018. The program didn't actually start until 2020. And again, the authority is through a Section 1115 waiver, and the flexible services program specifically supports nutrition and housing needs of eligible members, part of the ACOs. I'm only going to talk about our food as medicine work today, but my organization is also running a pretty robust housing program as well. The stated goals from Medicaid and CMS for the program are to improve health outcomes and improve health equity and reduce total cost of care. So we have lots of intermediate outcomes around improving food security and diet quality and really thinking about ways that we can engage members. But at the end of the day, this is what we're on the hook for trying to demonstrate that we're accomplishing with these programs. And the program is designed as a partnership model. So the guidance said to us, as an accountable care organization, don't just hire staff to do this. You can't just do it all yourselves. You need to partner with high capacity, their term, social service organizations. Different states use different terminology. Some say community-based organizations, CBOs. In Massachusetts, the term is FSOs, to deliver services. And so we took that to heart. We work with 6 nutrition partners across the state, and we work with 14 housing partners across the state, really working to identify the organizations that had the capacity, that had the infrastructure, that had the interest and the willingness to work with us in a very different way from the kinds of supports that they've been providing in the past. And they had to demonstrate experience with state and federal grants, with staffing models that really, assured community, that they could serve the needs of the community and think about cultural competency and language capacity, et cetera. So the flow of funds, which folks always ask about, Medicaid pays the accountable care organizations. And then, so we have guidance, and then we need to propose to the state what it is that we plan to do, get our social service organization partners approved, and then we pay the social service organizations for the work that they do. So in essence, they're providing fee for service rather than just providing a grant and kind of building that capacity. The social service organizations are billing us, sending us an invoice every month for the work that they do. And to be eligible for the program, a member must be part of our accountable care organization. So they need to be they need to be a patient at one of our health centers who's receiving Medicaid or Mass Health. And then they have to meet the health criteria. So there's complex physical health or behavioral health needs, members who are pregnant and have a high-risk pregnancy, or the child of a high-risk pregnancy after the baby is born, or someone who has high emergency department utilization. So if they're a frequent utilizer of the emergency department, then we're also going to support them. And then they also need to screen positive for food insecurity or housing instability to be eligible for the nutrition program or their housing program, respectively. So our interventions, as I mentioned, we have 6 partners across the state that are providing services. One is a food bank, one is a medically tailored meals program. A couple are, one is a elder services program that was providing Meals on Wheels meals and has really pivoted to be able to support a younger population and is actually partnering with another group as well. So we've got a variety of programs. And we think about the work in 2 ways. First is food referral, what we call navigation and support. And so we're connecting our members to a nutrition coordinator for resource navigation. We want to think about assuring that members are connected to programs like SNAP and WIC that they might be eligible for. And then they're assessing the household's food security needs and really providing supports that are appropriate for that situation. So they're helping to identify which from the allowable goods and supports at the bottom here is appropriate, and then also supporting them with nutrition education, healthy eating and cooking skills. And we're also able to provide kitchen items and appliances, recognizing that access to food is important and members need the ability to cook. And so we find that, things like pots and pans and knives and cutting boards and blenders and microwaves are important. In some cases, it's even, plates and forks and silverware. And in some cases, it's things like refrigerators. And we're able to really cover the benefit of what it is that members need. On the good side, the important piece for so many members, there are 4 different kinds of supports that we might provide. One is healthy food vouchers. And a lot of our members are accessing healthy food by a reloadable EBT card. We use that Solutran card with some of our members, or grocery store gift cards and other places where Solutran doesn't meet the retailers that are most common for shopping for those members. So we have a pretty wide range of members, geographies in Massachusetts, from urban areas to pretty rural areas in the western part of the state. So really trying to think about how we can get folks who are going to the grocery store access to healthier food and purchasing power. We have some members who are receiving home delivered meal kits. And so these are, think of it Blue Apron or HelloFresh. And so meal kits with healthy recipes and ingredients and, easy to follow instructions that allow members who would like to cook at home and who have the ability to do that with a fun and healthy cooking experience, but making sure that those groceries are delivered. And so they're getting exactly what it is that we want them to have. And so we can provide those to members where we think getting the right kinds of foods is appropriate for them. And then we have medically tailored meals. We recognize the top of the pyramid, not appropriate for everyone, but really happy to be able to provide medically tailored home delivered meals prepared by a dietitian, specific to the dietary needs of members who need to manage their health conditions. And then we also have a produce prescription program where we're increasing access to fruits and vegetables through, with one of our partners, it's an EBT card, and then in some places, it's actual home delivery of produce boxes from local farms and community-supported agriculture. So that's kind of the spectrum of our work. And the way that this works for us, and we think that this has been really successful, and that we have very much all of the partners involved in making referrals and making sure that we're supporting our members. So the health center is very much involving the provider, the physician or the nurse practitioner and the care team to identify eligible patients. We're primarily working with members who might be enrolled in our care management programs where they have the a health need that's important. They're making referrals to the flexible services program. And when they do that, they're sharing relevant information about the member, their situation, their goals, their health needs. As the ACO, we're managing those partnerships and the contracts and the referrals, and sharing compliance, and then we manage the budget and pay the invoices and evaluate the program and disseminate our learning. And then the social service staff are using our system to access the referrals call the patients, meet with the patients in person, conduct an assessment of their specific needs, set goals for what's going to make sense to improve nutrition access, and then provide those goods and service aligned with the care plan that we've approved. And then we're logging a lot of information and sharing updates so that that information goes back to the health center staff to assure that it's part of their clinical care. We're seeing some great outcomes. We've referred about 1,400 members from all of our health centers, nearly 300 community health workers and advocates from the health centers making referrals to the program. At any given time, we have about 2,000 active members. So again, we started this program in 2020. We're allowed to support members for 6 months, and then in some situations, we can expand beyond that. And what we're really pleased with is this 93% success rate. So 93% of members who are referred into the program get services. And so they're specifically, we know that those are closed loop referrals and those connections were successful. And we feel great about that statistic and think that that way in which we're working with our health center staff and connecting them with the social service organizations is really working to assure that these programs are successful. Over the past 4 years, we spent about $22 million on this work. And so those are Medicaid dollars that are going into the program. And we're seeing better diabetes control. We see hemoglobin A1C improvements for all members who have diabetes, about a 0.65 point decrease. And in particular, we see an even better decrease for members who are poorly controlled prior to enrolling in the program. So we see a mean of about a whole point in hemoglobin A1C for those members. We're also seeing a reduction in emergency department utilization, and we're finalizing some of our analysis, but we also see cost of care reductions, which is really exciting because that's really the ultimate question from Medicaid is does this program save some money in addition to doing the important things that we know are engaging members and improving food security and improving their health. So I'm going to stop there and would love to hear if there are questions and just have a little discussion about how things are going with all of you and if there's any other lessons that we can share. My goodness, my face is really big on that screen.
Thank you so much, Kim. Okay, we've already got some questions in the room, it looks like. And if you would like to just introduce yourself.
Yeah, sure thing. Jennifer Garner here. I'm with the University of Michigan School of Public Health, and I'm a researcher. And Kim, I really appreciate your presentation. The question I have based on the models that I've helped to evaluate is, given what we know about the state of healthcare access, not necessarily coverage, but access, particularly in rural communities, for example, how can we design these models? I noticed in your flow, everything comes from the provider level into the social service sector, right? But we also know that those individuals, despite screening positive for food insecurity, housing insecurity, and other needs, they're also already perhaps, I use the word privilege, but put a different word in there, in the sense that they have access to meaningful clinical care. Mm-hmm. So how are we also reversing these models so that we're finding folks who are perhaps accessing social services, but not meaningfully connected with clinical care as well, and kind of reversing the flow? I think that's maybe my prime concern at this point about some of these models. Thanks.
Yeah, great question. Yeah, and I think that we see both sides. And there are some states where you get a managed care organization sort of doing the opposite and just calling members that they know to have been experiencing homelessness or food insecure in the past, where they keep the provider completely out. Different models. We think that this one works really well because it means that we're addressing the needs of the members as part of their clinical care. And what we see from the Center for Medicare and Medicaid Services is this drive towards assuring that where we're using Medicare and Medicaid dollars, that it should be aligned with clinical care. So I think that's one piece is that we think that we're meeting that kind of a model. And more importantly for our health centers, we talk about workforce all the time. And I think at the end of the day, the challenge with access is also a challenge of workforce. There aren't enough providers, there just aren't enough staff, in addition to some of the other challenges of transportation, et cetera. And what we hear from providers and care teams is that the ability to address the needs of members is so important to their job satisfaction, to the way they feel about providing care. And we're asking them to screen, and the ability to leverage the flexible services program to truly respond to the needs is so important. So I think we feel good about building up the capacity of the health centers because we're providing a better work environment for those providers and care teams when they're able to truly. I heard one of our providers the other day saying, we're addressing the moral injury that we're inflicting to providers when we ask them to identify all of these needs and then not give them any resources. So we feel good about that, and think that what's most important as an ACO here, as we think about some of the Medicare and Medicaid work, is we build up access so that this is all possible. I think what we also see is lots of insurance companies and healthcare organizations considering what are the other ways, and how can we, run a list of members and make these benefits possible for them. And I think at the end of the day, most importantly, assuring that we're expanding SNAP benefits and addressing food insecurity at a base level is important too.
And I think we have a question for you on Zoom that Gabby's going to ask so the whole room can hear it.
Yeah, so as a community health center, how do you work with behavioral health partners in this space? Do you have mental health and substance use treatment providers in your larger referral network? And if yes, are these partners looking at similar metrics like ED utilization?
Yes, and yes, and yes. So part of the 1115 waiver in Massachusetts, there are a variety of ways in which we've used Medicaid to really expand behavioral health, mental health, and substance use work, including a program that we call the Community Partner Program. So a little bit similar to flexible services, working with community organizations to expand access to outpatient behavioral health supports and long-term supports and services. And so those organizations are also screening for health-related social needs and making referrals into our flexible services program. So there's a direct link. So you could look at that slide where I had the roles of the partners, and instead of healthcare or health center staff, you could think about community partner, mental health, and substance abuse staff. And so they are looking at ED utilization kind of broadly as part of their quality metrics. And then we're also looking at ED utilization for members who are enrolled in flexible services compared to a comparison group. So I think there's a lot of work that is happening across the state around quality measures, including utilization for things like avoidable ED utilization.
I think we have time for one more question from the group. And if no one jumps on it right away, I've got a question, Kim, that I think the whole room would agree. So you all, Massachusetts has been kind of a front runner in doing food as medicine with waivers. What is the one thing you know now about this that you wish you had known a few years ago? And you can be as specific and eccentric as you want with this response.
Oh, that's a good question. And as I'm thinking about that, I'm going to say I'm actually going to be at the Aspen Institute event tomorrow and Friday. So looking forward to talking with some of you, and I may have more thoughts on this as I get on the plane tonight.
Sorry, I didn't mean to stump you.
No, that's
it can be anything from don't do a lot of bananas because they spoil quickly or whatever.
There's so many things I wish I had known when we started this. As I mentioned, we started with kind of a blank slate. And so we spent a lot of time talking with our social service partners about these are the ways in which flexible services dollars can be used and how do we best utilize these programs. And so we really started from scratch with the ideas about how to make the referral and what's the right information and what's the length of services that we should be providing. And so I think we've learned a lot about what works there, and the ways in which we engage our healthcare partners and we engage our social service organizations, both in understanding the importance of this work and together, has been really, really valuable. And so we've adjusted the way we talk about our programs, the way we do our trainings over time. There's been a lot of investment in the process, and it takes staff time. So I think as we see what's allowable and not allowable from Medicare with some of the new changes, we're really advocating to make sure that there is enough staff time from the social service organizations to work with our members. We don't want to just when I was showing those various, there's a lot of ways in which we can, if we think about the food as medicine pyramid, there's lots of options, and different interventions support different members' needs. And I think it's really important that we involve our social service partners, our food banks, our dietitians, our community organizations that understand what's available in the community and how to best support this individual member, which might look different than that individual member. And we don't want to just put that on our providers and our community health workers. So where we're able to say, make this easy referral into this program, and the experts will take it from there and really support the patients, that's working really, really well. And so we want to be sure that we're able to, advocate for enough dollars that make that possible, that model possible in other parts of the state.
Well, you have perfectly.
Oh, can I ask one more? I know we're at time, but this is a question that's come up, I think, quite a bit in the work that the clinics are doing here in Kansas. So as it looked like a lot of your members, as they come into your various services that you offer, there's kind of that magic 6-month time frame. How do you handle moving clients or members out of that 6-month time frame as you're transitioning new members into the process, knowing that I think the challenge here is that after 6 months, 6 months is great, but we still know people need supports after that to maintain kind of the stability of what they've been able to achieve in that first 6-month period. How do you handle that transition period of starting new members while also continuing to support those that are kind of transitioning out?
Yeah. Good question. And it's hard. What we recognize is that foundationally, these are members who are living in poverty, and 6 months is wonderful and we see improvements. And then when they stop receiving services, food insecurity increases again. So that's the tricky part. One, referrals happen every day. And so it's not sort of a cohort that comes on. And so from a workflow perspective, it's relatively easy for the social service organizations because they know this member is, started now and has 6 months, and this other member started a month ago. And so there's from that perspective, it's staggered. And so the workflow and the kind of the capacity and the staffing is pretty easy. We really encourage them to talk to members up front about, this is a 6 months program, so let's get everything out of it that you can. Come to these nutrition education classes. What is it that you need to learn about how to cook, how to budget, how to shop better? Try some new foods while you have the opportunity for that. What are the kitchen appliances and the utensils and things that will help you down the road? And so we're really trying to think about what sustainable changes we can make. And at the end of every 6 month period, our staff, they're talking with members about, let's make sure that we talked about applying for SNAP. Let's make sure that that's finished. What other resources do you know how to access, all the available services in the community? And then we are able to re-refer some of the members who qualify. And so we have a process with our health centers to do that, which is tricky because, our social service organizations advocate for everyone should continue. And we'd love to do that, but obviously there's not enough money or capacity for that. So really trying to think about how to position this up front as 6 months. Let's make all the behavior changes and do all the work that we can while we're together.
Great. Kim, thank you so much. We'd all like to thank you for joining us. Appreciate it. Hey, safe travels to Kansas, and we'll see you tomorrow at the Aspen Institute.
Yes.
All right. Safe travels. Thank you so much.